Hello, my name is Annette B.A. I am the Program Director for the Geriatric Medicine Fellowship at Maine Dartmouth Family Medicine Residency, and I'm also the Medical Director of Maine Dartmouth Geriatric Medicine, which is a geriatric primary care and specialty consultative clinic in Augusta, Maine. I want to thank you for the opportunity to provide education pertaining to neurocognitive disorders, and more specifically, Alzheimer's and dementia-related disease, and building better screening tools for early detection and prevention. The learning objectives for this module are to provide an overview of neurocognitive disorders, mild, major, delirium, with a description of the four most common types of major neurocognitive disorders, describe benefits and barriers to screening, review approaches to screening and the clinical criteria for diagnosis, and discuss intervention strategies for prevention and treatment of neurocognitive disorders. As you can see in this slide, mentation is one of the essential elements or 4 M's prioritized in an age-friendly health system, which is a health system where older people get the best care possible with a reduction in healthcare-related harms, higher satisfaction with care, and optimized value. The 4 essential elements of an age-friendly health system include what matters, medication, mobility, and mentation, the prevention, identification, treatment, and management of dementia, depression, and delirium across care settings. In the ambulatory setting, this would entail assessing or screening for dementia, and if cognitive impairment is identified or suspected, acting on this assessment to consider further evaluation and manage manifestations or refer when appropriate. However, given the limited number of geriatric resources, primary care clinical teams should screen and manage within the scope of their practice when possible. As many practicing clinicians are aware, the U.S. Preventive Task Force concludes that the current evidence is insufficient to assess the balance of benefits and harms of screening for cognitive impairment. However, dementia is often unrecognized in primary care and significantly underdiagnosed, with estimates of greater than 50% of dementia cases being undiagnosed in primary care. And early stage or mild dementia is often undetected until an adverse event, such as medication errors or behavioral disturbances, occur. Also, the potential benefits of screening are vast and include removal of aggravating medications, simplification of care regimens, supporting caregivers, and providing anticipatory guidance and engaging patients and families in care planning, and ensuring that decision-making about medical interventions is sensitive to the dementia diagnosis, as well as providing opportunities to enroll in clinical trials for experimental therapies. So what are some of the barriers to screening from the provider perspective? These include discomfort in making the diagnosis, time pressure in busy clinics, failure to acknowledge signs or symptoms of cognitive impairment, minimizing family or patient concerns about cognition, or feeling that there is no point in making the diagnosis, as there are no curative interventions to offer. However, according to the Alzheimer's Association, the majority of older adults would want their healthcare provider to tell them if they were showing signs of thinking and memory problems. And they would also want to undergo further testing to learn more about the problem and how it might be treated. Also, early detection can validate concerns and provide a sense of relief in knowing the cause of symptoms. So how might busy clinicians in primary care approach screening? Well, the Medicare annual wellness visit is an ideal opportunity to screen. The Medicare annual wellness visit was introduced by the Affordable Care Act in 2011. It is a free service offered to Medicare Part B beneficiaries annually, and it's a part of a growing effort to promote preventive care among Medicare beneficiaries. It aims to prevent the onset of disease and disability and slow the progression and exacerbation of existing illnesses through health promotion and disease detection. So again, this is an ideal opportunity to screen for cognitive impairment. So what do we know about how to approach screening as part of the Medicare annual wellness visit? Well, it is not solely relying on a patient or subjective reports from an informant, but rather should include a valid and reliable screening test. A quick and simple screening tool used routinely across settings is the Minicog. Developed in 2000, this screening tool has a sensitivity, which is the ability of a test to identify those with disease or true positive rate around 76 to 99%, and a specificity, which is the ability of a test to identify those without a disease or a true negative rate of 89 to 93%. This test is positive if fewer than 3 words are recalled and there's an abnormal clock, or no words are recalled. A score of 0 to 2 means impairment is likely, while a score of 3 to 5 means impairment is less likely. The pros are that it takes less than 3 minutes to administer, it's less stressful for patients, and it's effectively used in multilingual populations with diverse socioeconomic status and education level.